Okay. All right.
Holy moly, that was a bit of a challenge getting this set up.
Hi, everybody. Thanks for joining. Sorry for the technical difficulties, but it looks like we have quite a few folks online. So thanks for joining Research and Discovery Grand Rounds today. My name is Bridget Jones. I'm a professor of pediatrics at Children's Mercy and part of Frontiers. So happy to be moderating this session today. So we just want to give a few updates on our upcoming Research and Discovery Grand Round session. Our next session is September 26th, right here on Zoom. Well, we'll have a film screening and a discussion on lifelines of care in the Kansas City community health workers making a difference. So this sounds like a really good Research and Discovery Grand Round. So I hope you all can come back for that. And then also wanted to highlight today, actually this afternoon from 3 to 4:30, our speaker today in High IQ will have the IQ Forum updates on regional opioid use project at the Kauffman Foundation Conference Center. So you can also go to the Frontiers website for more details, and Stacy can add any other additional details about this event later in her talk. And then I also wanted to put a plug in for everyone. After this, you should receive an email to complete an evaluation for our Research and Discovery Grand Round series. So please complete that evaluation and provide any input. And also if there are specific topics that you would like to see covered in our Grand Round series, please give us that information. We're really trying to build a series that speaks to the needs of our research community across all of the partners. So please let us know what you want to hear about. So with that, I will introduce our speaker, who is Dr. Stacy Farr, one of the co-directors of the Healthcare Institute for Innovations in Quality, or High IQ, at UMKC. And so she is going to talk about their work to improve the quality, equity, and value of healthcare in the Kansas City region. So welcome, Dr. Farr, and I think she's getting her slide coming.
Yes, hopefully here quickly. Are we seeing the right one?
You need to swap it.
Oh, darn. I'm going to actually switch to the other screen then. Sorry about that. Okay,
Yep.
is that better?
Mhm.
Okay, great. Well, thank you all for having me here for the Grand Rounds today. And I'm joined with some of my colleagues also with the Healthcare Institute for Innovations in Quality. And so we're going to present today a little bit more about our institute, actually. So transforming healthcare, the path to a learning healthcare community. And again, I'm Stacy Farr. I'm an associate professor at UMKC, director of CV Outcomes Research at St. Luke's, and then the co-director of the Healthcare Institute for Innovations in Quality. So thank you. And let's see, next. So I'm just going to walk through a little bit today, some background for the Institute, or background period, and then more about forming the Healthcare Institute for Innovations and Quality. I'm going to cover a little bit about our community engagement arm, some of our regional quality improvement that we do in Kansas City, as well as walk through one example, a code HF example, one of our projects. Then I'll talk about our training and education, as well as a brief summary. So kind of start, let me move this. I wanted to share, just as we all may remember, there was a landmark paper in 2008 from Don Berwick and colleagues. This was in Health Affairs Millwood, and it really introduced kind of the triple aim of healthcare, right? Where we are really, what we're trying to do is improve the experience of care, lowering the healthcare costs, and also improving better health. And, this was written, the lead author there was Don Berwick. At the time, he was the administrator of CMS, Centers for Medicare and Medicaid Services. And prior to that, he was the president and CEO of the Institute for Healthcare Improvement, or IHI. And then over the years, this was modified into the quadruple aim. So this was in 2014, where now the care of the provider, physicians and other providers, other healthcare providers was included to become the quadruple aim. And then just a few years ago in 2022, this moved into the quintuple aim to really include healthcare equity. And so I raised that, just to kind of point out that, we have a lot of problems in healthcare and the evolution is changing on where we need to emphasize our efforts. And we all know that we really need to change healthcare and improve it. These changes also are not new. I think what is important is that these problems are things that our country's been looking at since the 90s, which is almost sad to think about how long ago that was in terms of like for nearly half a century. But, so starting back even in the 90s, so in 1996, the Institute of Medicine, which is now, the National Academies of Medicine, they launched the effort to really start to assess and think about how we could improve the nation's quality of healthcare and laid out the vision for how to transform it into healthcare that can contain the attributes we want to see for high quality value and or for high quality care that's value based. And they had these two landmark reports, which is To Err is Human and Crossing the Quality Chasm. And the latter report, Crossing the Quality Chasm, laid out this call to action and this one was in 2001, to really make healthcare safer, more effective, more patient-centered, more timely, more efficient, and more equitable. And, it's just kind of important to realize that these are still issues today, and we are many decades down since then. So a few other things to note about this is that we have, decades later, we're now in 2024, and we're realizing document that we have these massive delays in how we get research taken up into clinical practice. And clicking. So we have this extensively long research to practice gap. In fact, this is, a 17-year gap that's documented in the research. And this has been updated again, that we still are knowing that 17 years is how long it's taking and that implementation science can help speed things up here. We know that we have wide variations in clinical practice, and we also know that if care is not evidence-based, it's really low value and not patient-centered. And so this being part of the Frontiers Clinical and Translational Science Institute presentation, thought we would also just put this in the context of translational science, and that these delays are really most notably observed in the T3 and T4 stages of translational science, and when we're trying to integrate this evidence into clinical practice and into communities. And these are also known in the literature as some of these kind of valleys of death in the translational pipeline. And really the point is we're not doing good enough. We all know this. We also know that a number of large organizations and experts have convened in trying to find ways to more rapidly integrate evidence into healthcare. So for example, in 2006, the Institutes of Medicine, again, now the National Academies of Medicine, convened a group of experts in a workshop on evidence-based medicine on how to re-engineer clinical research and healthcare delivery to make evidence more available and applied in healthcare more efficiently and more effectively. There was a workshop summary that was released in 2017, covered a number of topics relating to the learning healthcare system. And then in 2013, the IOM, or National Academies, convened again for the report, The Best Care at Lower Cost, to continuously learning healthcare in America. And this report, came from the fact that America's healthcare is really too complex, too costly. We can't be doing business as usual. Fast forward to 2018, the IHI released a white paper, the IHI Innovation System, talking about healthcare organizations could create their own innovation systems based on the needs of the organization and focus on improving healthcare delivery, to 2021, when IHI released Whole System Quality, talking about a holistic approach to health system quality across multiple levels of a healthcare system. And so now today, we're in 2024, and we have over 6,000 hospitals in the United States, and really each hospital very much operates itself as its own learning healthcare system. And we really, are trying to think a little bit differently in how we can evolve to a learning healthcare network or a learning healthcare system or learning healthcare communities, because we know that, these decades of us not moving the needle are not working. So we need to think outside the box and differently. And so we laid out our team, our kind of our vision for how to envision the evolution of a learning healthcare system into learning healthcare communities, and can see that if you'd like. There's the article. And from there, we also have developed here in Kansas City, the Healthcare Institute for Innovations in Quality. And what I'm going to call it high IQ for short. What high IQ does, the vision is really having Kansas City delivering the highest value, most equitable healthcare in the nation. And our mission is really to catalyze and facilitate multi-stakeholder collaborations to improve the quality and value and equity of healthcare in Kansas City. And for those of you that are familiar with our work, this is not new, but I think it's important to share. We have kind of three main strategies, and I'm going to walk through these a little bit so you can understand how we really operationalize and go about this. And the first of our efforts is really our dissemination and engagement arm, where really what we're doing is engaging with the community and talking about different healthcare topics in our region to see what are the pressing needs and what are things that we can move and work forward on and really get the community dialogue moving. And that is, we'll talk about that later, but we also, that was presented very, at the very beginning. We have one of those IQ forums today at 3 p.m. at the Kauffman Foundation, which is a really, really great topic and update to our opioid project, which I hope y'all can attend. We have our second arm, and kind of really how we operationalize and really go about changing healthcare to improve value and equity. And that is, this is a map of Kansas City on the left, but we have our regional quality improvement project. So what we really are doing is taking evidence and implementing this in a number of hospitals in Kansas City, and then measuring the impact that we're making as a collective community on patient outcomes. And then in order to do that work, as you can imagine, this is not easy because it's been well documented by all the experts in the field. And so we've also recognized that in order to best learn how to do this, we need to develop a training program. So we have a really novel training program called Tiara, which is training and implementation, actionable research approaches. And this is a really great way to kind of marry quality improvement with implementation science so that it can be a lot more practical. So I'll walk through a little bit all of these in greater detail. So the first of which I had mentioned was our dissemination and engagement arm. And as we discussed, these are most operationalized through our IQ forums. These are every other month. We have these community forums and really community conversations about important healthcare topics in our region. And I'm just going to highlight the upcoming rest of the ones for this year. So again, there's the one today, which are our institute updates on our opioid use project, which I really hope you can all attend virtually or in person. And then we have 3 more this year as well. And then also, if you are not on our listserv yet, you can reach out to me or any of us after. But if you are, there was an email just on Monday, and there we would really love all of your input on that survey so you can help inform what next year's agenda will look like in terms of which topics that we should be presenting, which are most important in our region that we should talk about, as well as if you have any speaker recommendations or if you yourself would like to be a speaker. And so now I'm going to move into our regional quality improvement projects and a little bit more about what that means and how we do that. So I wanted to back it up and just tell you about kind of how we originally even selected our priorities before I walk into what our projects are. And so I do apologize, the slide's a little busy, but I wanted to share with you, first on the left, like what we did at the formation of the Institute was we really started to conduct a number of qualitative interviews to understand kind of a needs assessment and kind of a landscape analysis of what is going on in our region in terms of what are the most important healthcare topics in terms of, from like healthcare leaders, from executives, and from a number of different healthcare stakeholders. And from a number of those interviews, what we did, as well as the payers, which I didn't mention, and then we identified 32 different topics from those interviews. And then, we kind of went through an iterative process where we would narrow that down to the projects that were ultimately selected. So we next went into developing a survey that we administered to the region in terms of identifying topics that were high priority, that were also actionable. And from there, we landed really on 11 topics. And I just used an example of one topic, that came up, which was, for example, like behavioral health needs, but it ultimately ended up being related to the fact that we needed, a lot more inpatient beds, psych beds for patients. And obviously our institute is not, capable of building and staffing, a hospital. So like certain topics ultimately weren't something that the institute could act upon in terms of implementing evidence into hospitals. And so were eliminated. But that's just an example. And then we moved into having, which are now known as the IQ forums. Some of you may know they were previously known as the Collaborate to Cure sessions or community forums. And we did, we presented those 11 topics there. And then through the forums and other venues, we voted on different topics that we would select for actual regional implementation at all of the hospitals here who so wanted to participate with us. And we ultimately landed on opioid management and particularly crises in the emergency department, as well as transitions of care for heart failure. So in terms of our regional quality improvement projects, our value improvement projects, our first phase, as we just so indicated, is our opioid project as one of our first projects. And so this project is KC EPIC, or Engaging Patients in Care Coordination. And I guess to back it up even further, I'm going to go back, sorry, but just at highest level, I won't go into great detail because I'll talk about other projects and you can find out today at our forum. But essentially this is an ED-based initiative in which we identify patients, that are presenting to emergency departments in Kansas City. And in particular, this was a partnership with the Missouri Hospital Association. But these patients present to the emergency department with acute opioid use disorder crises and are connected to bridge medication as well as peer recovery coaches who really meet them where they're at in a number of ways and help get these patients connected to community-based treatment to get them into recovery. And so our KC EPIC project, this partnership with the Missouri Hospital Association, kind of included a number of different phases. And what we did was, in step one, was really talk about the processes of implementation across Kansas City. And I'm just sharing a snapshot of, for example, a process map that was used and developed and is under review at a journal at the moment. But what we really want to do is talk about the process of how we're implementing this program across Kansas City so that we could help identify ways to improve that implementation. And then we wanted also to measure the impact. We really want to know what this program is doing on patient outcomes, right? And so we were conducting mixed methods evaluations, both qualitative analyses, and we are wrapping up analysis at this time, as well as quantitative analyses. And we're still doing some data cleaning and analysis, but you will find and get some preliminary results this afternoon, which is wonderful. Yeah, this afternoon at the IQ forum, you can see updates there. And then also in phase one, we have our transitions of care for heart failure projects. And this is, the carousel of heart failure, where patients with heart failure, present to the emergency department. They may or may not be admitted for their heart failure. And then they're, trying to figure out how they can get ultimately transitioned back home and try to stay in their home and live and manage their condition at home with their chronic heart failure. And so it's we have different interventions that intervene at different levels of that carousel. So this slide is just showing a brief dashboard of our projects. The two in gray are completed or ended, and I'll walk through one of these examples here in a moment. But we have our Code HF project, as well as our community support network or community services network for social determinants of health needs. And then I'm not going to go into great detail other than share with you that we're currently in planning stages. So for our phase two. So as we wrap up our opioid management project, we're still working on our transitions of care project, and we'll probably continue to work on that one for a while longer, but we're starting to think about what is the next project that we should take on as an institute so we can improve quality, value, and equity of healthcare in Kansas City. And what's really emerged is the tremendous problem that we have, not just in the US, but very strongly in both Kansas and Missouri, is maternal mortality. And so this is just showing, maternal deaths per 100,000 live births over time. And you can see these are kind of all the industrialized countries. And you can see how the US is really an outlier in a bad way, right? So our maternal mortality is really, really poor and needs dramatic intervention, as well as not only is this, the aggregate, but when you break that down by different sociodemographic characteristics, you can see that there are really massive inequities and disparities and things that need to be eradicated. So that will be kind of where we focus next. And just to share a little bit more about that, we have obviously already identified this as by the health systems and other stakeholders in our community as a high priority for our region. There's obviously a lot of local and national focus on maternal health and maternal health equity. And we have a really wonderful planning committee started. We have a number of different healthcare providers and clinical champions, the Missouri Hospital Associations. We have community-based organizations. And we also have a new research scientist who will be working with us. Her name's Kat Istis, and she'll be also working on that project. We're very excited. And just a number of really wonderful organizations who've really been putting their minds together and how we can best formulate our interventions for implementation. And we're collaborating with a number of others in the community who also have synergistic, plans and priorities in terms of reducing inequities in maternal health. For example, Health Forward and the Kansas City Health Collaborative. And so from there, I'm going to just take a quick water. But I was going to share a little bit more about one of our projects just as a case example so that you can, I guess, it can be more concrete for you as well in terms of the work that the Institute does with the hospitals. And so I'm going to use the example I'm going to use is one of our transitions of care for heart failure projects. This is called Code HF. And what this is, so this article is sharing with you really the origin of a risk model that is it's really what this is a tool that is used in the emergency department. This article was based on a multi-center study, 86 hospitals in Canada, and ultimately what it did is develop a risk model to say how can we risk stratify patients who have a history of heart failure and come into the emergency department to see who we could safely discharge home as opposed to who needed to be admitted. And so based on this study, what we've done is, kind of operationalized a Code HF pathway in the emergency department. And so to walk you through what that looks like, here you have, like a patient who's presenting to an emergency department with a history of congestive heart failure and dyspnea or shortness of breath. And, you see if you can basically rapidly diagnose them and give them IV Lasix, where, the clinical team are speaking and making decisions together. And based on these risk models, if the mortality risk is greater than 1%, for example, then they're obviously rapidly admitted to the hospital anyway. But if you can, based on that risk model, identify who's at extremely low risk of death, less than 1% or whatever threshold the health system wants to implement, then you can observe them for responses. And if they're not, if they're not getting better, obviously they can still be admitted to the hospital. But otherwise, if they are feeling better, there's, the opportunity to educate and conduct shared decision making. And if the patient still wants to be admitted, there's obviously still the ability to go, into the hospital. But otherwise, if they're comfortable then being sent home, they can be discharged safely from the emergency department. Follow up with the cardiology team within 7 days. They'll get a follow-up call the next day. They also get educational materials. And so what we did is we implemented this pathway at one of the health systems in Kansas City, 4 hospitals, and through St. Luke's. This is an article that, if you want to read more about it, talked about the experiences and that implementation. And some of the preliminary experiences and outcomes that were observed at St. Luke's Health System were that these heart failure discharges from the ED, we noticed that there was a 49% relative increase on those that were on the Code HF pathway. Also, that the length of stay in the emergency department actually was decreased by almost an entire hour, by 54 minutes. We also found that heart failure 30-day readmissions post-ED discharge, for those that were on the Code HF pathway, they had a 24% relative reduction. And also that cardiology follow-up post ED discharge, that those on the code-HF pathway had a 93% relative increase. And then finally, that avoidable heart failure admissions, and so are those that are those kind of less than 48-hour stays in which there's a number of billing implications. And so they get billed as an outpatient stay, for example. And so that's not good for the hospitals. But for those that were on the code-HF pathway, we saw that there was a 21% relative reduction in those avoidable heart failure admissions. And so a number of wins, as you can see. But there were also challenges in this implementation. So this is showing you that, for example, in 2018, of 1946 patients who were eligible for the code-HF pathway, that only 12% of these had code-HF run on them. And so, one of these main challenges that we've observed is the variability in use across the ED physicians. And so when you look at the proportion of eligible patients, and you can see that, most of these ED physicians were rarely using the code-HF pathway. And some, but not many, were often using it. And so we undertook efforts to really try to improve adoption. And what we did was, use an implementation science kind of determinants assessment. We modeled this off of the TICD, which those in implementation science will know, but that's one of the determinants assessments called the Tailored Implementation for Chronic Diseases. And we conducted 21 different stakeholder interviews and did thematic analysis and found 10 different themes, and then matched those to strategies and recommendations, and ultimately created a recommendation report. And we're still revising the manuscript, but and working on implementing some of those recommendations into routine care. And I'm just sharing this as an example that that work was submitted at the Academy Health Dissemination Implementation Conference last year, and did get nominated and won the kind of the best poster award at DNI for health system innovations. And it was called Utilizing Frameworks and Recommendation Strategies for Implementation of a Heart Failure Admission Decision Aid. So I share that project, and then I wanted to move. So then from those kind of one health system kind of learnings, we worked also, which I think is a wonderful collaboration to demonstrate, with these competitive health systems, but that we've now also launched this at KU. And so what we did here was this, the team provided the EPIC code to KU, and, it was really wonderful coordination and teamwork. I must say it was a really great project management implementation. We had great data sharing to support different reports on the use. We're still collecting some additional data to support and enhance both the implementation of that at KU, but it has moved on to other health systems, so which is very exciting. And then looking at the time, I'm going to move into our next arm. And so the next kind of body of work that we do, again, to do all this regional quality improvement work, obviously you need to know kind of how to do it. And so this is where we have launched our training and education arm of the Institute, where we're really moving and growing in implementation science, implementation practice, and quality improvement. I'll talk a little bit about that in our framework. So as many of you know, implementation science is the scientific study of methods to promote the systematic uptake of research findings and other evidence-based practices into routine practice. And I'm just sharing, Welcome to Implementation Science, the article when this came out. And you can see really as an example of how young the field is why I share that, as well as journal itself. Implementation Science only began in 2006. And then on the other side is kind of thinking about quality improvement, which is, been around forever. Not forever, they've both been around forever in different ways, but the fields are convening, is what I should say. And so in terms of quality improvement, what is quality improvement and how can it transform healthcare? One definition is, the combined and unceasing efforts of everyone, healthcare professionals, patients and their families, researchers, payers, planners, and educators, to make the changes that will lead to better patient outcomes. And really, what is needed and important in the way in which we operationalize and think about training and education is moving into the marriage between implementation science, which is still new and very academic, ivory tower theoretical, but also into how we can marry that with quality improvement as a discipline into really implementation practice. And we know this is needed in the field and well documented as well, that there's these, calls to action on how we can actually integrate implementation science into practice and improve outcomes. And I'll just share it again. There's one of our abstracts that we've also presented. And so our main program that we have is called Tiara. So this is called Training and Implementation Actionable Research Approaches. I'm just going to very quickly, without a lot of detail, but share with you, it's a 7-module series. This is a certificate course, both through Frontiers as well as through our institute. So for learners, and this is a wide variety of people who would be interested or who could benefit from Tiara, including primarily, I would say, people who want to be change agents in healthcare or in getting evidence into even communities. And so a lot of different healthcare providers, people who work in quality, physicians, people who are in training, or also researchers who want to work in a more applied fashion, or other healthcare stakeholders. And so we have, it's a 7-module series, and I'll just share with you the 7 modules. But our first is implementation science and quality improvement. And we talk about the differences, the synergies, and the overlap in the next directions. We talk about current situation and targets and how to kind of identify problems. And really what we're doing is taking this quality improvement framework and foundation and really layering in implementation science knowledge and terminology and concepts so that it becomes more actionable and more effective. And then we have evidence-based practice interventions and determinants, the recommendations, making an action plan and doing iterative improvement, and then other applications and considerations. And then we have our final, which is the keynote on the state of implementation practice, our TR scholar presentations and certificate ceremonies. So that's a high level. And I just want to share a little bit of our first cohort, our first live cohort. I should also say, we have 2 different offerings. So you can take a kind of live with us, and it really runs in the spring semester. Again, I said it's 7 modules, and so they run every other week, basically from January to May. There will be one coming in 2025, or there's also an on-demand option in which you just want to take it self-paced and do it on your own. So both are available for enrollment at this time. But I wanted to share some of the results from our cohort that took this with us synchronously in January through May of 2024. And so in that we had, 35 attendees, and here's our Tiara graduation ceremony, the certificate ceremony, and the keynote at the Kaufman. And we had just high level in terms of satisfaction. Overall, there was 100% that were satisfied with rating this excellent or very good. And we're working, not still, but we're working now actually on different expanded partnerships. So I share that not only if you're interested or if you know, but just so everyone is aware. We have a number of different health systems participate in the PCORI Health System Implementation Initiative, which is a large national initiative to really get evidence taken up into healthcare systems. We've also been speaking with Stanford, Hopkins, and other institutions as well. And then I have our QR code here for more information and registration. I really wanted to have our registration page updated prior to this grand rounds, but unfortunately, I think it still has the 2024 dates still exist on that QR code, but you can still register just the same, and they'll be updated very soon for the 2025 offerings. But this is the QR code. You can go register, get more information, and learn a little bit more about Tiara. And then I just share one of the quotes that I think is wonderful from one of the scholars that, this program is exactly what I was looking for. I wanted to learn the fundamentals of implementation science, but in a way I could practically apply it in the real world and in quality improvement. And then this is, when you do click the QR code, this is kind of the page you'll see, and then you can scroll down and choose the options for enrollment. So that's, our primary kind of training education arm. We're really proud of it. We think it's a wonderful opportunity for our region, for people that want to learn a little bit more about both fields and how to do their work more effectively. And then honestly, I think I'm at some of the last slides here. So we have a number of opportunities for engagement with anyone in Frontiers or beyond who wants to work with the Institute. So as you kind of noted, I'm just kind of summarizing our three main buckets of activities that we had and ways in which people can engage and think about working with us. So again, we're doing regional quality improvement. So we're working with, there are over 30 hospitals in Kansas City, and we're working with a large network of them where we are helping implement evidence into their health systems and then measuring the impact of that on patient outcomes. And so we have opportunities for, working with sites on implementation, building more awareness and getting more of the community engaged and excited about this work. We also have our Tiara program, as I just walked through. We love your support in building awareness, but also if anyone has interest and wants to enroll or spread it to others, we would love that. And then our IQ forums, those dissemination arms, we would love people to attend. Again, we have one today at the Kaufman, as well as spreading awareness, or if you want to be a speaker or have a topic that you're really passionate about and you would love to lead a forum, we would love to have people weigh in. And so, in summary, we all know this, right? That US healthcare needs monumental and innovative change as we move to value-based healthcare. And, learning healthcare communities like the one that we've built here with, High IQ can really help kind of ease this transition while improving the value and equity of healthcare in our community. And we do have a number of opportunities to engage, to learn, contribute, and so we can all work together. And those are my slides, and I thank you. And we can, I guess, turn to discussion questions.
Thank you, Dr. Farr. That was great. A lot of great information and things to think about. So we can open it up for any questions. Looks like someone maybe came off mute. I don't know if they want to ask a question. So I can start us off here. So one of the things you talked about was equity is one of your pillars. Can you talk a little bit more about kind of how you've integrated equity within the different work within high IQ?
Yeah. So I would say it's we're learning, but there's a number of different ways in which we have operationalized it or could continue to do it over time. But so far, some of our efforts are primarily like selected or designed because we're trying to intervene on populations that need extra assistance. And so I think one of the best examples I could give is within our transitions of care for heart failure project or projects, carousel. One of our interventions is really, I think it's just really novel and wonderful. What we're doing is we're screening for social determinants of health needs with kind of a robust screening from the inpatient side. So it's inpatient heart failure patients. We're working with a number of hospitals in Kansas City, and we're doing a randomized trial where if we screen for these social determinants of health needs, can we change the model of care from getting these patients referred to one, kind of like the hub and spoke model, like to one hub, where then we can give them 90 days of, wraparound services. There's this in-home assessment and 90 days of wraparound services, including, transportation, appropriate meals, medication reconciliation. Do they need extra supports in the home? It's kind of identifying truly what all their needs are and then delivering them robustly for 90 days. And we're measuring how that, impacts quality of life and readmissions, satisfaction. And if we can make a dent, obviously, in some of the social determinants of health needs. And so, I'd say, yeah, some of our interventions are specifically geared to trying to help populations that need more assistance and have these needs. But in addition, we've been trying to think about, like, for example, with our upcoming regional QI project, which is going to be focused on maternal health inequities, we're really trying to focus on, where we've landed a lot on is preeclampsia and, hypertensive disorders of pregnancy, because, Black and Hispanic women, across the board, everyone is, especially in the US, is doing horribly, but it's something that is disproportionately negatively affecting, women who are Black or Hispanic. And so we want to design the interventions that we implement at the hospitals to specifically try to remove some of these inequities.
Yeah, I might just expand on that. I think there are several ways in which we do this. I mean, one is, first of all, a lot of the projects we're targeting have known SES or racial or gender disparities in the processes of care. And it's our fundamental belief that if you improve the infrastructure of healthcare delivery, everybody benefits and the disparities will lessen. When we do the analyses, we do stratify by race, gender, often age as well, SES status, ethnicity. So we provide reports both before and after on, care stratified by those populations. Then, as Stacy correctly said, a lot of the projects we are targeting do disproportionately impact certain populations of patients, and therefore, if the implementation works well, then they should benefit as a group more even than others. And then, our group is doing a lot of active work. We're helping lead a very large national trial that is randomizing patients, but only patients getting into the study are Black, Hispanic, and women. And so there's been a tremendous amount of Corey-funded work about how to better present and engage people. Now, this isn't really research per se, but there's a lot of bleeding over a lot of the learnings from that in how we understand and directly address traditional distrust of the medical system and research in general. I mean, most of our work, there's no informed consent, there's no research. It's really a more rigorous way of improving quality. But I think those are a summary of the strategies that we're using. We're targeting important conditions that differentially impact different subparts of our population. We are stratifying the analyses by race, ethnicity, gender, et cetera. And we're continually trying to learn and infuse the implementation of these projects with knowledge we're gaining about how best to engage communities that have been traditionally underrepresented.
Okay, great. Thank you. Yeah, I think that's an extremely important point as far as understanding the community aspect as far as uptake of, there's one thing to implement the guidelines within a clinic setting, but it's another thing for the patient to do what the guidelines are asking you to do. So I think that's a really important aspect of considering that community engagement and community voice of it. So thanks. And I think there was a question there. I think you already answered it, Dr. Farr. Is there an enrollment limit for Tiara trainees? There's no enrollment limit. And I think that's the link that's there in the chat.
Yes, yes. Yeah, and I'm happy to expand upon or answer anyone's questions about Tiara as well, or anything.
Any other questions from our audience? There's a quiet group today.
It is. Surprise, 54 people and no one wants to talk.
Hi guys, this is Lisa. I was just going to say, I really encourage people who are online to, connect their colleagues that aren't already connected with Frontiers to access, for instance, the recording of this talk, because there's just so much in it. There's so many valuable things that we could be sharing with colleagues, we could be sharing with our students. And so I just wanted to give a little shout out for that, because I know that I'm actually going to be trying to connect this talk directly to some of the students that I'll start working with next week. So thank you.
Thank you.
Yes, thank you.
Any other questions? So I did have another thought. So as far as barriers for implementation, what are some of the barriers that you all have recognized that are common across the medical institutions that you've worked with? And also, have you done work with like smaller groups, like private practices? And I can imagine, there's many more barriers or different barriers in a small practice setting versus a larger institution?
Yes, no, those are great questions, and I have many answers. I would start by saying, in terms of, and I just, for everyone, I just dropped the actual institute's URL in the chat. So if people like aren't on our listserv or just want to see more about, the Healthcare Institute for Innovations and Quality and what it looks like or how to get involved, there's also the website there. But in terms of implementation barriers, but also where we implement and learn. So one thing is we are a pretty small team. While, we're a fairly young and new institute, and we're really trying, where we're at now is we're really trying to demonstrate that what we're doing with these regional implementations at multiple hospitals is improving the value and equity of healthcare. When we have that proof, then we can, scale and grow, scale and grow. But we're still a little bit in the proof stage. And so I only say that we're still a fairly lean team, meaning, our locus of control is not as large. Like we're intentionally not able to do large implementation regional quality improvement projects at, hundreds of primary care practices, for example. And so our locus of control has really been, centered on the hospitals here, of which there are still, many. And actually, it's a really wonderful culture here in Kansas City of collaboration and partnership. I mean, that's kind of why I shared even the example that I did with our Code HF project, because it's taking, two healthcare competitors in cardiovascular care, for example, St. Luke's and KU, and showing that, look, these hospitals are both participating, collaborating, and doing it for the right benefits of patients. And so, one is yes, our locus of control has really been centered on the hospitals themselves versus other practices at this point. Not to say that couldn't change, in the future. And then in terms of implementation challenges and barriers, I don't know even the right way to address that question, because I feel like if you've done one implementation, you've found a million barriers, right? But I think what's great about the way in which, excuse me, but the way in which that we've really designed like how we're implementing these projects at these hospitals is that we are, we're doing this implementation kind of practice assessment where we're really understanding what the barriers are at each site and then implementing strategies to overcome them. At highest level, I think, the biggest one that you could see or identify or that's noted right away is trying to make sure that there's both top down, so kind of the C-suite, this is a strategic priority of the health system or the hospital or the unit even, but then also the bottom up. And so like what I think has become most important is knowing that there are clinical champions or some owners on the boots on the ground individuals who really want to own and run and have passion for the initiatives, because they're going to contribute a lot to the success, while our team, helps support implementation and support those teams. That's been a really important part. Another barrier, as you can see, we're trying to conduct really robust, evaluations of the impact, and that requires obviously data. So I would say one other challenge that we've had is just getting and obtaining the right data from the right people. So working through legal and regulatory to get the data that we need to support the robust evaluations we want to do. But otherwise, to back it up further, like, what we do is based on the intervention, we're doing kind of a determinants assessment. So we're really doing an identification, like we take really an implementation assessment and tailor it to that intervention and ask a number of stakeholders in a number of different ways, through qualitative interviews, through surveys, through meetings, what challenges are. And then we really kind of tailor, with implementation science, what are strategies to overcome them so that we can improve implementation. And they've been, they vary. Some are system level, some are patient level, some are knowledge, some are, they vary based on project. But I would say the biggest initial ones that we always have is the right clinical champions and match between the top and bottom, as well as getting data needs in line. I don't know if John would add any other ones.
I don't know how I could improve upon what you said.
Oh,
Great.
the good thing this is recorded. I will just take that. Any other questions, anyone?
don't see anyone coming off of mute. I don't see any.
But I mean, but we've really, I mean, the Institute's fairly young. I think we only, I can't even remember when we got our official approval. Was it 2020? You know, and but we started the conception and the idea and these regional projects in late 2017, early 2018. And so, you know, we're still very young and new. And if people are passionate and, you know, this is something that really sparks their interest and passion, we do really definitely encourage people to get involved in all the different ways that you can, or that you're interested in through Tiara, through our IQ forums, through our regional projects. Really want to make an impact together.
All right. Well, thank you so much. I have a thank you here in the chat. Thanks so much for the great presentation. And then like was mentioned, if you want to disseminate this presentation, please go to the Frontiers website. You can find it there and send folks there to view it, as well as our other research and discovery grand rounds series. And please complete your evaluation when you receive it, to continue to give us ideas of the content that you want to see. So thank you all for attending. Have a great day.
Thank you.
Dr. Farr.